Okay, good morning. First off, let me thank Claudine, obviously, for making this all possible, and thank you all for attending. As Tim mentioned, I'm faculty at the University of Michigan, a transplant nephrologist and health services researcher. I'm also a member of the Kidney Epidemiology Cost Center, which we refer to as KEC, which is a multidisciplinary group of people, including faculty, data analysts, and programmers and project managers that have done a lot of the work behind the projects and the data that I'll be presenting. I'm also one of the deputy directors for the USRDS. Bruce Robinson is the other deputy director, and Rajiv Saran is the director of the USRDS. What will I be talking about? This is kind of an overview. It doesn't necessarily have everything in order, but some of the ideas I wanted to convey is, number one, what is surveillance? I use that term in the title. And it's kind of borrowed from one of the projects that's funded by the Centers for Disease Control. And so I'm going to talk a little bit about that because I like the way they frame the problem of kidney disease. I'm going to give an overview of the three large national kidney disease projects, including the USRDS, a CDC-funded project, and a Veterans Affairs or VA-funded project. I'm going to give a overview of national trends in chronic kidney disease and end-stage renal disease, and just a handful of areas where certainly at the 10,000 foot level, we can identify potential problems that could be areas to target for improvement in patients with kidney disease. And along the way, mentioning some of the lessons learned and challenges that we met in trying to kind of utilize the data we have to identify these trends. So since I'm the first speaker, I think it's important to just go through very briefly some definitions. So end-stage renal disease, or ESRD, some people will call that ESKD, or for kidney disease. And that includes anybody who essentially needs renal replacement therapy, and that comes in the form either of dialysis, of which there's a number of varieties, or transplantation. Chronic kidney disease, or CKD, has as its formal definition reduced glomerular filtration rate, or reduced kidney function, or the presence of kidney damage, which is often indicated by the presence of spillage of protein in the urine, for at least 3 months. So technically speaking, to call it chronic, that's the chronic component, excuse me, is the requirement for it to have been present for at least 90 days. And there's different stages of it, which I'm not going to get too much into details, but essentially 5 is bad or close to dialysis. 1 and 2 represent scenarios where you've got evidence of kidney damage, but your GFR is not necessarily reduced below 60. And then 3 and 4 represent different levels of reduction in your kidney function. The other thing, which I'm not going to talk at all about, but I think it's important to bear in mind in the broad view of kidney disease, is acute kidney injury, or AKI, and this is increasingly recognized as particularly important. It's something that we certainly are beginning to track more and more in some of these kidney disease projects, and because it is something that is much more likely to happen in patients who have underlying chronic kidney disease, but also it's a risk factor for subsequently going on to develop chronic kidney disease. So acute kidney injury is when you have a sudden drop in your kidney function, often because, for example, you have an infection or something like that. So as part of talking about or transitioning to talking about surveillance, one of the things is that kidney disease can be viewed as a public health problem. And number one, as I'll show you some data for, there's a very large health burden on society. Patients with kidney disease have all sorts of medical issues, a high rate of hospitalization, very high rates of mortality. There's reduction in quality of life. And again, I'll have one slide just showing the costs. There is a tremendous cost in this population of patients. The other thing that I won't, again, show on in terms of the trends, but there'll be a talk on it, and I think Deirdre Cruz will be touching on this, is that kidney disease is something where there's certainly disparities in outcomes, disparities in care related to kidney disease. And then finally, and I think this is probably one of the themes that I'll kind of come back to at the end, is that we probably need to do more upstream in the form of prevention, both primary prevention, meaning before people get kidney disease, people who have risk factors for kidney disease, but also in early stages of kidney disease, trying to prevent progression. You'll see the outcomes are quite bad once people get to advanced kidney disease and end-stage renal disease. So this is where this kind of public health view that focuses on prevention, I think, is key. So I use the term surveillance, and so what is public health surveillance? And this is a quote from an article that, kind of a seminal article that reviews this concept. But it's the ongoing systematic collection, analysis, and interpretation of health data essential to the planning, implementation, and evaluation of public health practice, closely integrated with timely dissemination of data to those who need to know. So this is just a kind of a conceptual model. You need to get the data. You need to put it in some kind of analyzable form to derive the appropriate interpretation, and then get it to the people who can start to act on it. And then you need to continue the cycle to see, if the actions have led to improvements, and where you need to continue to put resources, and where you continue to need to do work to improve the ultimate outcome. And so a few more words about public health surveillance. So historically, it's applied to infectious disease. That's initially the largest focus, say, for the Centers for Disease Control. But increasingly, the idea is being applied to chronic disease conditions, diabetes, and also kidney disease. And again, some of the uses for putting it in this term and monitoring various aspects of a chronic disease condition is that so that you can track the burden of disease, understand and get your hands around the magnitude of the problem, be able to monitor what's happening, how care is being delivered. If you make any changes, you can monitor to track for any improvement in outcomes. And also, to a large extent, it's also important to generate hypotheses and stimulate further research. So tracking patterns of disease can also give you some insights about what may be the underlying causes of the disease. And some of the data sources that can be used, and you'll see examples of this throughout the rest of my talk, are formal health surveys where there's a specific kind of design to go out and ask people questions or gather data from them. Registries of disease patients, you'll see examples of that. What I'm calling information systems, where you leverage healthcare data to get some of the information you need. And then there are some aspects that can really only be done in a research context, so cohort studies, where the only way you can get the information is through kind of a detailed research design approach. So I'll start with some of the project, and there's three. One is the United States Renal Data System, the USRDS. Just by show of hands, who has heard of the USRDS? Okay, so most people, and I would kind of expect that. For the USRDS, it's one of the longest standing of the projects I'm going to be talking about. It was initiated in 1988 in response to the growing size and cost of the ESRD population. And essentially, it certainly is how it started, is a registry of ESRD patients. And this was possible because essentially, and this actually dates back to 1973, all patients who require renal replacement therapy are eligible for coverage by Medicare. And because of that, all patients, regardless of their primary insurance, have to submit a registration form to Medicare, the 2728 form for those who may know. And because of that, we're able to identify the vast majority of patients who become end-stage renal disease patients in the United States. So we have essentially a full capture of those patients. And a lot of the work that's done is supported by the NIH, by the NIDDK in particular, as well as Medicare itself, CMS. And we track trends in the incidence, prevalence, mortality, costs, and various aspects of care and outcomes. And again, I'll show you a few aspects of that. There are annual data reports produced. They're available on a website. They're also more recently being published online in American Journal of Kidney Diseases. The USRDS also provides the data in a researchable form for those who have the resources to do that. And most recently, that data is actually free of charge. The other thing it does is it provides linkage to researchers who want to link their own cohorts of patients to the USRDS in order to get accurate ascertainment of the development of ESRD. Beyond just ESRD, it's also, since 2008, introduced an entire volume on chronic kidney disease as well. And a number of data sets are used, and this will be a theme in the other project I mentioned as well, to get at various aspects. So Medicare claims, CrownWeb, which is a web-based form for data submission for dialysis facilities to Medicare. Clinformatics, which is essentially a commercially available data set that's provided by a large healthcare insuring organization, provides information on patients who are essentially have health insurance through their employer and potentially their dependents. Veterans Affairs data, which I'll show a little bit of, and then NHANES, which is again, many of you may have heard, but it's a large national survey, the national survey. So it's not specific to kidney disease. It looks at various aspects of health, but it provides data in the form of lab data, serum creatinine, which allows us to get at kidney disease, and therefore it's been used substantially at providing kind of an estimate of the national burden of kidney disease. So the other project is the CDC CKD surveillance system. And this was started in 2006. It's been a joint effort by teams at University of Michigan, that's Rajiv Saran, and then Neil Poe is the other principal investigator, originally at Hopkins, and he's since moved to UCSF. And the idea, again, is to take more of a public health approach to CKD with more of a focus on the kind of the upstream aspects of it and preventive aspects. And as part of that project, we identified several major topics to look at. And this just gives a breadth of the idea of the breadth of topics that are examined within the project, including looking at the burden of kidney disease, or the prevalence, the incidence, awareness of it by the healthcare system, but also by patients, various processes and outcomes, health system capacity, so the availability of nephrologists, and then the health consequences, mortality. And then here, to emphasize the preventive aspect, we also track the risk factors for kidney disease, like how many people have diabetes, for example, and age as well. Age is certainly a risk factor for having reduced kidney function, and as the population ages, we're going to have more people with reduced kidney function. So, as opposed to ESRD, where we have a registry where we can capture virtually all patients, chronic kidney disease is much harder to get a handle on. There's no national database of kidney disease patients. So we need to use an amalgam of different data sources to try to get some kind of flavor for what's happening across the country. And we do that by using different data sources, some of which I've already mentioned. So, employer-based insurance data to get at a younger employed population. The Medicare population is older and sicker, and we have claims information from them that we can look at. Medicaid is something the project has not used yet, but is planning to, which again has claims data to identify kidney disease potentially. And again, that has a whole different kind of a population, kind of an underinsured population, a more vulnerable population. We have registries to get the kind of the end-stage renal disease component. The SRTR is a transplant patient registry. And then the population surveys, including NHANES and BRFIS, which are surveys of patients to identify, again, kidney disease, but a whole bunch of other things as well. And then cohort studies. So we bring all that information together to get a snapshot of what's happening across the country in kidney disease, even though we're not really looking truly at national data because we don't have it. And website was launched in November of 2012. If you just Google CDC CKD, you will get to it. How many people have been on this website or know about it? So mostly this table over here. So this is an opportunity for me to make a plug. So CDC CKD in Google will get you there. And this provides a lot of the information that we derive from analyzing those data sets. And then finally, and this one really probably is off the grid, so to speak, a little bit, because we've mostly been working on it, and there'll be a few abstracts at this year's American Society of Nephrology meeting out of this project. But it's funded by the VA, and actually not their kind of research arm, so not their HSR&D arm, but by VA Innovations. It's an operational kind of project with the original idea being essentially to establish something like a registry using the VA data. The Veterans Health Administration is essentially the largest national integrated healthcare system. There's about 7 million active users of healthcare, and the VA has long standing been using electronic health record data, and a lot of that data is available in a warehouse. So it's national electronic health record data, and importantly, unlike some of the other data sets, includes biochemical data. So creatinine. Serum creatinine results that can give us a better picture of kidney function than just claims-based or diagnosis codes, although it has those elements as well. So this is going to be a fairly quick kind of view of the nation in terms of ESRD and CKD. So a lot of this data is based off of the USRDS, and what this provides is time trends in counts of new patients. So new patients coming to ESRD, both transplant and dialysis. And what you see is overall, it's over 100,000 new patients a year in the United States. The other point is that if you look here for the last several years, there's actually looks like it's plateauing a bit. So whereas there was a fairly sharp increase over the years, over the last several years, there's been kind of a plateau. And that's a little clear when you look at it as an incidence rate, meaning it's indexed to the population and also adjusted for age, sex, and race. And so when you do that, so this is a fairly complex figure, but these bars represent the incidence rate. And these lines, these vertical kind of thin lines, have to do with the percent change over the previous year. So when they're above this line, it means there was an increase. When they're below, there was a decrease. And what you can see is, again, it was increasing, some kind of a plateau, but it appears to have declined or at least stabilized the last few years So something's happening there to slow down the rate of new cases. It's hard to know. We actually don't know exactly what's happening there. Is this something that's related to measures that have been put in place in terms of trying to improve the care of kidney disease, better use of medications like ACE inhibitors to slow down the progression of kidney disease? What's happening here, we don't know it precisely, but it's perhaps some good news. The other thing is the prevalence. So how many people are necessarily new, but are currently existing on dialysis or as transplant patients. And that is continuing to grow. This, again, is the percent change. So even though it's still positive, the amount by which it's growing is slowing down. And prevalence is really a combination of how long you're on dialysis or have your transplant and how many new cases are added. And we know the new cases added have slowed down or are perhaps completely stabilized. So some of that drop in the percent change is probably related to that. Some may also be because patients are living longer, because you'll see in the next slide that mortality is also going down. But if you want a quick snapshot of numbers, we have over 600,000 ESRD patients in the US right now, and a little over 400,000 on dialysis and about 200,000 transplants. Mortality rates. So mortality rates are coming down. Again, really good news. The rates are still high. So this is put as numbers per 1,000 patient years, but you can think of it in terms of percent. So back here in dialysis, it was about 25% of patients on dialysis every year would die. We're down to, about 17%. That's still very high, but it's certainly a big improvement. There's, nobody, again, we don't know exactly why it's getting better. Similar trends are seen in the general population, so some of this may reflect that, but perhaps it's a little steeper compared to the general population. So there may be things we're doing. One of the things may be improvements in vascular access. Certainly in prevalent vascular access, we're doing a better job in terms of giving people fistulas as opposed to leaving them with catheters. That could be one potential contributor. And then costs. So I don't think we need to worry about the different divisions here, but the point is that the costs have been going up. And we're talking about, for the ESRD population, for Medicare, this is Medicare expenditures, it's a little over $30 billion a year. So Medicare essentially spends about 6 to 7% of its budget in the ESRD space, even though the ESRD population is less than 1% of Medicare patients. So what about CKD? So this is data from NHANES, and again, CKD is very common. So you saw Claudine say about 1 in 10, and that's the number that we often throw around to be kind of on the conservative side. If you look, and this is by stage, so a couple of things here is that, and this is in different cohorts. So over time, there's been an increase compared to the early 90s, but it's probably stabilized here. And some of you may have read the recent article in Annals of Internal Medicine that looked at this in a fairly detailed way. And it looks like there may be a stabilization in recent years. However, it's still stabilized at around, say, 14% or so, which is about 1 in 7 patients, and this is the adult population. This is awareness of CKD. So this is in NHANES. So it takes patients with various stages of CKD and asks them a question about, are you aware that you have weak or failing kidneys? And even in stage 4, which is quite advanced, it's still, less than half say they know about it. And some people have, there's been work at asking this different ways. Some people would say, well, maybe it's because the question's not right. But even if you ask it various ways, you don't say weak or failing kidneys, you say kidney disease, protein in the urine, something like that. it's still low. Doesn't change this by much. So what about health system data? So health system data, so the NHANES goes in and by design gets a measurement in everybody. So you can get the true prevalence of disease. The problem with health system data is that you have to leverage what data is there for you. And often that data is there for clinical reasons or for billing reasons. It's not there by design to go out and find cases of kidney disease. So there are issues and limitations with that. If you go by diagnosis codes that are in billing claims, they're decent specificity, meaning that if it's there, it's probably that patient probably really does have kidney disease, but there's also low sensitivity, meaning that you miss many of the cases and probably you miss certainly the early cases. So what about if you do have biochemical data? What do you do with it? You have multiple serum creatinine measurements. Do you, in order to call somebody CKD, do you impose that 90-day requirement? That means they need to have had their creatinine measured multiple times. The moment you do that, you're picking somebody who's probably sicker than usual because they're getting their labs measured more frequently. So now you're only looking at the sickest population. So how do you handle that? If you're trying to track within the healthcare system what proportion of your patients have kidney disease, what do you use as your denominator? Do you only take the people that were tested and say how many of those have kidney disease? Again, the same problem there is there's a reason why they were tested. So how do you do it? And a lot of the data we do, we kind of just present the entire population of people who are using the healthcare system, whether they're tested or not. And that's how we calculate prevalence in a lot of the data we do. Issues with race. A lot of healthcare systems don't collect that information, or at least don't collect it consistently, and it's needed in the GFR estimating equation. And then there's the whole issue of the GFR equation. In the time that we've been working on these projects, we've changed from the equations from the MDRD to the CKD EPI formula, and issues of lab standardization. So there are problems. So nevertheless, we proceed and try to present the best we can. This is Medicare data, and this is based on codes. And what you can see is that, well, if you go based on codes, there's an inexorable kind of rise. But remember that codes are capturing not just the true presence of disease, but also just the awareness of disease. This is in the VA data with biochemical data. And this I'm just giving as an example to show how you define CKD. You can get very different numbers. So here we use a liberal definition. So just one value of creatinine that shows a reduced GFR, just a dipstick that's positive, or a claim, and you can get as many as a third of the VA population. The VA population is older and quite a sick population, but up to a third will be called kidney disease. If you use a more strict definition requiring chronicity, requiring a quantitative measurement of protein, then it's about, it's less than half of what you capture here, about 1 in 6. So how you define it is really important in terms of who you identify. So, quick overview of some trends that are perhaps some areas to focus on. So, one is urine albumin testing. So, urine albumin testing is really important to try to quantify the prognosis of any patient with kidney disease. It's certainly explicitly something that many providers know to track in diabetics, but it's also important in anybody with kidney disease. And what we see is that, and these lines, so this is patients who don't carry a diagnosis of chronic kidney disease. This is patients with a chronic kidney disease diagnosis. And there's been improvement over time. But even in diabetics, it's about 40%. And if you've got kidney disease, a little better. But the rates are still fairly low. And there's some nuance to this. So it doesn't mean that we necessarily expect this to be 100%. But it does show that perhaps there's room for improvement there. And we know this is an important aspect of identifying patients at risk. And this is VA data, and I just wanted to show it to show how consistent the trend is even outside a completely different healthcare system. And I can't show you the clinformatics data just because it's going to be in the report for the USRDS coming out later this year. So I can't release that data yet, but it's essentially the same trend as well. So completely different populations, same kind of trend. So I think this is an area that may bear attention. The other thing is this is VA data showing use of angiotensin inhibitors in diabetics with chronic kidney disease. Many of these patients, probably should be on one of these agents. Probably not 100%, but it's about a little over 60%. And again, the question is this something that you can use data to track? And this is something for which we have clinical trial evidence of benefit in the right patients. Vascular access use. So this is now getting closer to the ESRD end. We have a lot to do there. What we'd like is for people to start dialysis with a fistula. What you've got in this top line is people with a catheter. So vast majority of patients hit dialysis with a catheter, and we've hardly moved this line in a decade. And a lot of that probably relates to preparation. So a lot of it comes before they even start dialysis. And this is just an idea of pre-ESRD nephrology care. This is pulled off the 2728 form that's submitted for Medicare entitlement. And what it shows is that, less than half of patients have more than 6 months of nephrology care prior to starting dialysis. And you see a gradient. The longer they have care, the more likely they are to have a fistula. It goes down as you have less and less care. So to summarize, I think I can say that there's a lot of room for improvement in the care of patients with kidney disease. I think one of the themes is that it's important to focus on those upstream efforts. That's likely to be where we're going to be most impactful. By the time people get to dialysis, a lot of the damage is done, so to speak, and you see how high the mortality rates are, although even there we've managed to move the needle. If you're going to focus on those upstream efforts, it's likely that primary care physicians need to be playing a big role in that. A lot of patients with early stage CKD or even just risk factors for CKD, they're going to be managed by primary care physicians, not by nephrologists. So figuring out ways to engage the primary care physicians and thinking about ways in which nephrologists and primary care physicians can work together is going to be really important. And then finally, as you can see, you can use various sources of data to help kind of get a snapshot of what's happening. And I've shown it in terms of the function of these projects has been kind of high level, national level. But obviously, I think part of the goal of the project that Claudine and others are working on is to looking at it at a more, at a healthcare system level. And that's going to require, other challenges potentially. So I just want to acknowledge Dr. Rajiv Saran, who's the PI on all the projects, our staff at CAC, and the funding from the NIH, CDC, and the VA. Thank you.